Good morning, everybody. So I think this is the Irop meeting, and traditionally attended by the Irop members, but others are usually welcome as well. And yeah, I think we're going to have just a small audience. So few announcements from the society itself. One is Dr. Azad sir is unable to make it because of a problem, personal commitment problem. So Dr. Subhadra Jalali ma'am, please occupy.
We are in Simmer's course next hall.
And the second thing is, of course, that Professor Parijat Chandra will be giving the oration today. And we'll, since sir is not here, we thought we'll give you the certificate plaque at the annual meeting in Surat, where we usually have also the Rajvardhan Azad oration, where we usually invite a foreign faculty. So both like how we combined madams in Dubai. Right. So I also have an early flight, ma'am. So I'll do mine, then I'll stay for the oration, and then I will leave. And Dr. Karobi is on the way. Dr. Supriya is also.
Others are also in the next hall. Simmer's lecture, they're all coming.
They'll all come. Great. So mine is a talk. I'm going to talk about the anti-VEGF. I think the important thing about anti-VEGF is that it's obviously we're seeing so much more of its use because of this aggressive posterior ROP or aggressive ROP. And we have to now understand that after injection, there is going to be some amount of reactivation, and there's going to be some amount of incomplete regression. So this term of incomplete regression is what we now call persistent avascular retina. So till where do we wait for these blood vessels to grow after anti-VEGF? Could we just close the door, please? Yeah, thank you. If we have 2 disc diameters or more of avascular retina, it is considered significant persistent avascular retina, and that maybe we need to follow up, if not manage, and that is where the debate lies. So this is one point of contention which does not have any guidelines yet. The second one is this regression. So when regression is incomplete, and that incompleteness is either because of the blood vessel pattern or the way the ridge reduces. So where are we on that? And this used to almost never be seen after laser. We know that now for maybe 3-4 decades. But with anti-VEGF, this has become an issue. The reactivation is another aspect where either they will reactivate in terms of the ridge itself, the plus itself, or both. Or they could reactivate in a new place where blood vessels have grown a little bit, or in the old place, which is where the posterior zone 1 disease was, or in both. So basically, it can happen anywhere. Now, I'm going to actually present just 3 main publications that came out through the society. This one was led by Anil, was published a couple of years back, where we looked at the survey of the Irop members and to see what is the preference, what kind of anesthesia, which drug, how often are we doing bilateral same time, and so on. So I think the current indications as far as they go, to summarize from the survey itself, and then some recommendations that were made, not on behalf of the society, but from the recommendations itself. Firstly, we are now recommending it for zone 1 and posterior zone 1 or zone half. Poor media with a stubborn tunica vasculosa, as the Arvind group showed maybe 1.5 decades back, could be a relative indication, although sometimes one can do laser as well. No access to laser became a very big aspect during the COVID pandemic, or lack of expertise to do so. And but once you commit a patient to anti-VEGF, one must know that there is a follow-up issue, and they have to commit to that, and you have to explain that and document it very importantly, because we've seen late recurrences. The whole world has seen late recurrences up to 2 to 5 years after injection. So if you've not committed to that and the child detaches after a couple of years, you will still be medically and probably legally liable if you've not explained it to them. And the recurrences which I just showed in terms of example, and the follow-up in vision, because I'll show you how that might affect neurodevelopmental outcome and vision as well. Now this is from the CPG, Clinical Practice Guidelines of the NNF. Again, many of us are on that writing group. So this is something that both the clinicians, the pediatricians, and the lawyers will be looking at. So suffice to say, the 2 red boxes here, we don't use it for zone 2 RO. I think this is important to understand, because that works so well, laser works so well. But there are, I know, colleagues who will give injections for zone 2 as well. So I think once this comes out now, and it has come out as guideline, it's going to be an important thing. And the bigger one in the box down below is that commit to follow up at least to 65 weeks of post-menstrual age. And at that point of time, one must decide what to do. Now, whether you agree to this or not, and you are going to laser earlier is a different story. But here it is in print in the clinical practice guidelines. The next one is a more recent publication which Dr. Dogra led. And I'm just going to summarize from that narrative. We basically talked about different clinical scenarios where anti-VEGF can be used in both India and middle-income countries. And I'm going to summarize it here. Topical anesthesia, way to go forward. There probably was some debate sometime back. Topical betadine, the SAFER or the SAFER protocol is going to be followed. Injecting both eyes on the same day, this topic came up during the IC on ROP, whether we should inject one or both, why not, and all of that. So I think as long as we have consent and we've understood the possible risks, yes, you can do it. Special consent is required. Both the VRSI for the adult anti-VEGF and the Irop Society have consent, so I think one must follow that. And explain to them that it's going to possibly be a combined therapy. So after anti-VEGF, the baby may almost, very likely, especially if you're using ranibizumab compounds, require laser. And when, where, we'll talk about soon. And finally, the follow-up, which I just showed you. Now here, for example, is a case that it's a video shot actually. Just go back. Right. So here's a one-eyed child. One eye has already gone into a detachment. Both eyes have been injected. Couple of months, years ago. This child was just hovering around in the community, was told that the other eye is completely normal. But here's to show you there's a very significant persistent avascular retina almost 12 to 14 months after injection in a one-eyed child. So this is of course an extreme example, and this one was like a 14, 15-month-old baby which we had to do under sedation. But if you want to preempt this, then one must learn to do laser much earlier. This is something that I was involved with a group of neonatologists, both in India and abroad, who looked at the neurodevelopmental outcome of, this was basically a meta-analysis, this is not a study. So they just looked at a whole lot of publications that looked at neurodevelopmental outcome in the past 1 or 2 decades. And some of the findings here are a little bit alarming, and I think we must be aware of it. I'm not saying this will shy us away from using the drug, but here it is. So any baby who had no ROP and any ROP, so any baby with any form of ROP, even if it's type 2, had a higher risk of neurodevelopmental outcome. Now one might argue that, okay, this is because of having risk factors. Now it goes one step more. So if the baby required treatment requiring ROP, then the risk of cerebral palsy were even more than type 2 ROP. Let's move that a little more to the babies who were used with anti-VEGF had a higher odds of cognitive impairment than the laser group. Okay, so especially with cerebral palsy, it seems that, and this was after removing the confounding risk factors of the other, other conditions that are known to cause NDI. What's very interesting is that it was found that those babies who were injected and then lasered, what we are now talking about combined therapy, had a lower risk of NDI than babies who had only anti-VEGF. Now, this is a smaller number in this study. So what does this mean? Is laser protecting in some way the neurodevelopmental impairment? If so, how? So the only argument is that if there's some amount of ischemic retina all the time in the eye, and that is contributing to some way in a sort of negative feedback to vascularization, not in the eye, but also probably important organs, and laser mitigates that risk, maybe that is something. Of course, a prospective, long-term, larger study will be required, but this is a meta-analysis. One has to understand that this is everybody's work for the past 10, 15 years, bringing out some highlighted points. So what does this mean? 2 things. One is combined therapy is probably here to stay, and number 2, a second injection probably is not a good idea, because already you may have worsened the chances and now you're going to further improve. So that no repeat injection, and this was specifically made to neonatologists, as a group of neonatologists. So yes, the angiography unit is now there in the neo, but very honestly, and I've told this to the company as well, the resolution of this device is not as good as the older neo. So there is some issues that while they have combined the fluorescein, their resolution, especially of the peripheral retina, is not good. Now in terms of follow-up attrition, I think this is just example after example, so I'm going to skip a lot. All of us have seen these vasculitic subtypes of aggressive ROP, which are often misdiagnosed as retinal retinitis or even uveitic conditions, are nothing but a subtype of AROP. And these are the ones that will usually have a large persistent avascular retina or recur in zone 1, not just in zone 2, and one must. So here's a baby, I'm trying to highlight that 4.7 kgs, of course, we are doing it under topical anesthesia, but with FA guidance, you don't always need FA, but you need to set your limits on when you're going to and where you're going to do the topical or general and when you're going to do the laser. Social factors, very important because they might not be able to commit to a very long-term follow-up. Now this is the Arvind group where they showed that the supplement laser and when and where, and you can see that of course this study for them was only through Avastin, bevacizumab, and they found that the duration was up to 4 months. So I think this is 6 to 8 weeks recurrences, usually earlier recurrences in ranibizumab and later recurrences. This is something that we are now going to have a consensus with the mentors of the Irop. So this is not yet published. This is just the initial framework. So I'm just going to spend a minute here. If there bevacizumab, then you do weekly follow-up for 4 weeks and 2 weeks after that, every 2 weeks after that. If it's ranibizumab, you want to extend that weekly for a little longer because the recurrences may happen earlier. And after you've ensured that the blood vessels are heading towards zone 2, then every 2 weeks is enough. So every fortnightly, and then 2 conditions will occur. Either there will be a recurrence or there's persistent avascular retina. So if there's a recurrence, of course you treat, there's no questions asked there. And if there's persistent avascular retina, and this font is small, so then you see which of these conditions are fulfilled. Vessels reaching zone 2 anterior, a postmenstrual age of 48 to 52 weeks, a weight of the baby, which is the current weight, about 4 kgs or more, and these are all subject to variation, of course. No facility for general anesthesia or parents unlikely to follow up. And there is an asterisk there which says there's going to be a surgeon's preference. So you will have to change that based on your preference and the region that you are catering to. And if you are going to do it under topical, that's when you decide, or they commit for a long-term follow-up and you do it under sedation much later. So I'm going to repeat this slide, and that's where we are talking about zone half or zone 1, a stubborn TVL, no access or lack of aspects. So now the legal aspects is something that I put a blank slide here. Through the society, we are engaged with National Law School in Bangalore. We are planning to come out with a workshop with the leadership of VRSI, AIOS and Irop and the legal fraternity on what is the legal standing of the off-label use of Avastin. And I think we started off with the story of Avastin and ROP, but the workshop is going to take a slightly larger perspective of off-label drugs in ophthalmology, and the idea is to build up modules with the law course, so eventually have a 4-day legal course like how the executive MBA happens in IIM, where ophthalmologists will be able to commit a weekend and be refreshed with medical legal aspects of ophthalmology, and happy to say that ROP will be one of those big modules. So we were going to do it a month ago, the elections and AIOS has delayed that a bit, but we are restarting that dialogue. And please block your date, July 21st, 22nd, the annual meeting and the West Zone combined will be in Surat. Thank you so much. So, yes.
Yeah, just on the use of anti-VEGFs, we were talking about bevacizumab and ranibizumab. I think within ranibizumab also, now that we are using more and more of razumab,
Yes.
and especially with the JSSK scheme coming in and we are getting that free.
Yes.
So we are seeing a very variable response with razumab compared to eccentrics.
Correct.
And sometimes I've had to re-inject some of these babies at 2 weeks,
Yes.
depending on what the response I was getting. And the recurrences also have been relatively earlier, though we have still not analyzed our data, but that just by personal experience I'm talking about.
That's true.
So
And
that's also
that's what
something
we
that
were
we'll need to look about once we go into biosimilars.
And people have anecdotally reported, at least from India, some of the members have shared that after the biosimilars were used, whenever the reactivation happened, it was more the classical ridge than persistent avascular retina. So not sure. And then these are people who were using the eccentrics and now have shifted to. So and again, what Simar is mentioning as well.
No, I had just a few questions. One, you said that the PAR is described as 2 disc diameter.
Diameters of avascular.
Suppose there is a half disc diameter, then it's not PAR.
No, so there is now, I presume, a clinically significant part.
Yeah, that's what I said, because see, so many normal babies also, because there was a discussion in literature that normal babies also can have some power, because I am concerned that in my department, many people, they keep on sending for laser. And they even say that, examine under GA, because this patient was screened somewhere and we don't know whether there is a PAR. But, if it's just a half disc diameter or 1 disc diameter, we should not persist that this is PAR and this will get lattice and this will get, hole. So we should be very clear what is the current definition of PAR, which is 2 disc diameters, which is quite a substantial part. Like, it would be like, okay, zone 3. Zone 3 is like, 2 disc diameter. Or maybe it's 3 disc diameter. So at least some of zone 3 is vascularized or not. So I think we need to understand this, what is this 2 disc diameter of PAR, and not label every bit of avascular retina as PAR and start pushing them for laser. That is one part. Second, in the article from Arvind, they said that if the eye did not show growth of vessels in 2 weeks, 2 visits apart. Now I have a problem with that, because some children, they grow slow. Recently on the WhatsApp group, there was somebody, he said for 4 weeks, so it's not growing 6. Now at 8 weeks it is growing. Even ETROP and all, they have written that sometimes it can take 6 months for, I'm saying, a non-injected eye to grow. So if a non-injected eye is going to take 6 months to vascularize the zone 3, injected eye will take longer. So I think that, that 2 week is too short a time for me. Like, I think we should keep on watching. There is no hurry. And especially, of course, we have GA, we can laser at 1 year, there is no hurry. So, but we should give that time and that understanding that it is still growing, there is nothing to worry. It has reached zone 3, and keep a watch. But there would be patients where, but all these articles, they are not talking of, I keep on saying this in all the meetings also, they are not talking of the systemic anemia. Our data clearly shows that anemia is such a huge risk factor for detachment, for non-regression, and also that should come in our discussion, guideline, presentations, that, every time, please correct the anemia. If we don't correct that, we will have more of this PAR and more of these things happening. And so in your flowchart, you said recurrence or PAR. The third category you have not put, where this completely vascularized, which is like less than 2 disc diameters of PAR. So that we need to put. But I think your question, whether particular drugs are causing more laser, I think literature has already shown. We all have the data. I will be talking little separately to all of you, those who are in the front lines of making the guidelines, that yesterday there was a very good session. I don't know how many of you attended it, the National Symposium on Retina. There's a gentleman from the Army Institute, the regional institute. He presented some things about the legal part, and they are working with the government of India on various aspects. And I discussed with him about this ROP and all. He said, we'll get you all on that. And the agenda is to push the government to allow bevacizumab for ROP. And we need to collect that evidence that that is the best drug for these babies. And it should not remain off-label. They should give us legal sanction and DGCI sanction to the companies also to manufacture adequate single dose, and we should be able to give the drug. So all of us now have the data. I will talk to you people from PGI, from all institute, from you, that give your data of how many re-lasers you had to do for A drug, B drug, C drug. And if we present that to the government through those groups, then we may, get that sanction for the best drug. Because we are struggling, so many lasers we have to do now. Back to square one,
Thank you, ma'am. I have to leave a little early because of my flight, but I want to complete and introduce our oration awardee. So we'll switch gears a little bit. So Professor Parijat Chandra, of course, needs no introduction to this audience. He has completed his bachelor's in UCMS, went on to do his post-graduation senior residency, and serves as faculty of RP Center, All India Institute. He has, of course, being in the Premier Institute and being involved in ROP work for so long, has been so instrumental in training so many of his, and inspiring both junior and senior residents, both not just here, but from neighboring countries as they observe under him. He's also been he's been a principal investigator and a co-PI for several international and national trials, most recently the Rainbow as well, and he continues to follow up. He's an outstanding surgeon, and his contribution, he's almost always called to give talks, surgical talks on ROP. It doesn't mean that he is not familiar and an expert in other aspects as well. He has served in the National Task Force, both from the neonatology perspective, from ophthalmology, from the society, and he's been part and a mentor for the society from its very inception in 2016. A very soft-spoken person who doesn't really talk about himself, doesn't involve himself in any of the other non-academic activities, so it's very hard to sometimes spot him in a crowd. But Dr. Chandra, we are extremely proud of you for the services that you provide to the babies, to the nation. And it's a very particularly important oration that we award to you, because this will be the first Michael Tracy oration after Dr. Tracy is no longer with us. And of course, he has been a mentor and a teacher to so many of us, including our president. Professor Azad, not unable to make it here today, especially since his personal thanks to you. You have been with him as both a student and then as co-faculty. And we will, of course, repeat this honor and oration award for you at the annual meeting. And we are, of course, going to call you now to speak about your pet topic on how to improve outcomes in advanced ROP. So, Professor Parijat Chandra.
Great. He's so sweet, Tom. I say he's so sweet, Tom. Parijat. Yes, you can have. ये साइन कर देंगे। उसका दो जगह नाम आ मेरा नाम तो इसमें है नहीं। No, I'm not presenting. So actually, I'm replacing Dr. Azad because he didn't come. So he asked me to.
Yeah. So we can start. Okay. So thank you, Dr. Anand, for this kind introduction, and thank you for the Irop Society for this honor and this oration. I'm very grateful to you for considering me for this oration, and my teachers, and of course my mentor, Professor Azad. So I'll be talking about just a few words about Dr. Michael Tracy. So Dr. Michael Tracy unfortunately passed away in 21. He was the chief of adult and pediatric VR surgery at the ARC and the William Beaumont Hospital, Michigan, USA, and in several other universities. He was often called the father of modern pediatrics.
Mic thoda ठीक करें.
He was often So he was often called the father of modern pediatric surgery, and he got the AIO's highest honor in 2021. And of course, he has touched all of us in some way or the other. Many of us have gone there and taken training, and there were many who got to experience him and his techniques. And of course, as rightly said by the AIO, he touched the lives of a lot of not only children, but ophthalmologists also worldwide. So fortunately, due to my mentor, Professor Azad, I had an opportunity to meet Professor Tracy in 2009 in the World ROP Congress, where I was organizing secretary, and that was my first interaction with him. And Professor Azad was the chairman, and I got to meet Professor Tracy then. And then again, thanks to Professor Dr. Jalali, we were able to meet at the pediatric surgical workshop, and she invited me there. And thank you, madam, for that. And that gave me an opportunity to meet Professor Tracy and many other luminaries like Dr. Gopal, and you can see a very young Dr. Jalali there. This is 9 years back. A lot of people are there also, which you will be able to identify there. And there I got an opportunity to meet Professor Tracy in person, and I really cherish this photograph, so I thought I'll put it here. And many of us had an opportunity to interact with him, work with him. Like Dr. Jalali wrote this very touching thing about Dr. Tracy, and Dr. Benekar and Dr. Dogra and others had an opportunity to work with him and in different academic projects as well. So coming to the topic, so I'll just talk about a few things about how to improve outcomes. It might be targeted at some young people as well as some trained experts here as well. So maybe we can take away something, whatever you find useful. Just to show you how this case came to us, it had got traction in both the eyes, and you can see it's already progressing. Unfortunately, the child got sick, so it could not be operated. He became like this. So the message we want to give here is that basically we need to operate early. The later the ROP progresses, the more it's going to become difficult to operate these cases. So why is it so? Because you want to deal with these cases when it's an early TRD and not when it becomes something like in the right photograph, when it's much more difficult to operate. So the cases which I'm showing here are much more easier to operate, and you might find it much more easier for beginners to start with rather than going to more complex cases, because it's a lower TRD, there's less peripheral TRD there, the macula is spared, there's less neovascularization, and possibly you'll be able to do a lens sparing surgery, allow easy instrument access, and a good traction relief will be possible in these cases. So for newcomers, this is a more difficult scenario to start with, and possibly it will you will not have a good outcome when you try to operate these cases. So these are already too late. It's better to refer early. So how are the outcomes in stage 4 ROP? So this is a case which you see here, and it was operated here, and this is what it looks like. So the outcomes are very good if you operate them in time. Another case here, if you operate this case, again, here posterior barrage laser is also done in this case. And again, the outcomes are very good if you operate these cases in time. So the same case I showed you earlier, if it goes into stage 4B, then obviously although the traction has gone away, the macular pucker does not go away so easily, and the outcome will be not so good. So it's better to go in when it's in stage 4A ROP only, not delay it beyond that. So this is another concept which we talk about a lot, that we need to operate both eyes. So Dr. Jalali has been doing this for a very long time, and basically you need to operate both the eyes together. Earlier we used to operate the worse eye, and by the time the child used to come to the second eye also used to become worse. So it's better to do both the eyes in the same time and expose them to single high-risk GA rather than doing it again and again. Obviously parent counseling is very important in this. And this is just an article which I recently read about by Dr. Jalali about compassionate and SOP-based counseling. This is a very important concept which we often overlook. And it's only when the problem happens do we realize that how important the consent is and what to do when such babies get into trouble, or the parents, how to manage the parents. So I think it's something worth looking at when you especially want to get into these problems. So ROP surgery, let's talk about something about surgical setup. So obviously I like to do 25G surgery, but 27G surgery also is a good situation. I'll just come to that. So I try to use the VOC Mini Quad XL lens. This works very well for me. Many people like to use the Zeiss Resight. Sometimes in very small eyes, you might like to use the ocular payment lens, which again fits very well onto these eyes. We need to understand that the trocar cannula, which is available for the adult system, is pretty long, right? It's like 8 millimeters if you see here. So if you stick it full in a whole preterm, very preterm eye, is going to go through and through. So you need to be aware that this is a problem, and you can't insert them fully. You need to operate a different technique to do this. And of course the 25G short is something available, not available really in India, but this is something which newcomers can look forward to, and at least these kind of injuries can be avoided. Just to show you the technique how I like to do it, so this is just to show you the indent has been done, and now the trocar cannula is going in, so just sliding it through and inserting it. And what I'm just trying to show here is that I don't like to insert it full, so it goes in half, then I just slide the cannula in and I take the rest out. So it doesn't have to go the full 8 millimeter inside, and you can get away with it. Just to show you that suppose there's a big TRD there, then this is just a GV paint I've marked, and then you can just, the TRD is there, you can rotate the eye, and then you can almost make it straight. And but how much eye can you rotate, that depends how much the TRD is, but this way you can just sit superiorly itself and avoid the whole thing. And of course it's much more than Dr. Dogra Simmer is here, and they have described this all nasal approach. So if it's absolutely nasal, then you can try to sit temporally or nasally and try to do this from the other quadrant, just like you do a cataract surgery. Traction relief is very important, so dealing with the radial traction which is happening here, and then you deal with the vertical traction, and you deal with the circumferential traction. And just to show you how it's being done here, in the same case, so again the horizontal, radial traction is being relieved here. This band usually forms, this is the band which later leads to the falciform fold. It's important to cut this and relieve the traction again vertically, so that this whole TRD can fall back. It will bleed at times because these are new vessels growing into the vitreous, so better to cut all these and let it fall back. So nothing to worry about the bleeding, you can always dithermize it, and but the idea is not to leave the bleeders there, so that it can eventually go away. So again to show you how the traction looks like, and the same concepts again, relieving of the vertical traction, relieving of the radial traction, relieving of the circumferential traction, just to show how this thing can fall back. This is when the retina is attached a little more posteriorly. This is zone 1 stage 4 which is happening. So here again you can see the traction will leave centrally, so that all this retina can fall back. And these are fresh laser marks given just before surgery. by the LIO. Sometimes very difficult to approach the periphery in a very small eyes if you try to do it through the internal laser. So doing it with the LIO sometimes just before surgery can be a much better idea under GA. So this is how it comes out in the end. We like to do sometimes 27G surgery in a very posterior cases because sometimes these instruments have flex and it might be difficult to operate in the periphery. So this case particular, you can see it's heavily lasered aggressive ROP and there's traction in the periphery and the central traction is there. So Dr. Parag likes to operate a lot of these 27 cases. You might want to look up his article from the Arvind group, how they like to do so much of 27G. And this is just to show you 27G vitrectomy being done here, and so this is just again the same traction is being relieved, and so not much manipulation is required with 27G if you just want to deal with something very small at the posterior pole. The closure is also much better than other gauges, and you can just relieve this traction and this thing will go back. So what lies below the hemorrhage is very important. Sometimes you get hemorrhages coming at the posterior pole, so they should not be ignored because they could there could be an underlying retinal detachment beneath them. So if you don't deal with the hemorrhage early, you could end up with a very badly puckered retina in the end. So just to show you, so this you can see is a case of aggressive ROP and it's already been lasered somewhere outside, and he was referred to us because of this hemorrhage. So you see again, I'm trying to do the vitreous has been removed and this all blood is being removed, and so once all that is gone, so then you see this all this tissue is being relaxed, and this is the last band. Very difficult to remove this. If it can't be removed, better to leave it rather than just get a big tear there. So I'm trying to do this, and it just came out by chance here, and then just trying to relieve all the folds over the macula, so that the macula, so retina has memory, it can fall back. So as you can see here, it has all gone back, and it looks okay now. So don't ignore the hemorrhages over the disc and the posterior pole. They could house underlying macula pucker. This is sometimes when you have a lot of things stuck behind the lens. So again, you want to remove all this. So this is all stuck behind the lens, so you have to be very careful. You don't end up, cutting the posterior capsule or pulling open the posterior capsule and having a cataract later. The lens is a very important component of the eye's refractive structure, so you don't want to damage it in any way. So once you've removed all that with diathermy and proper suction and cutting, then you can all this can just fall back, and you have to be very careful. You don't need to remove every bit of it if it's not coming out because it avoids lens injury. Something else I like to do a lot, if you got progressive ROP despite laser, as you see it's already lasered, there's extensive traction happening here, extensive neovascularization. So again, similar case you see here, so again I'm trying to remove it. All the traction is being relieved, and once you see all this traction is gone, then the vitrectomy is done over the ridge and all this is removed, and so now here PVD is being done at the posterior part, as you can see here, and then just to pinch you and show you how vascular the thing is, So just by doing surgery alone, this is not going to go away. So in the end, I'm just going to inject anti-VEGF in this eye, and you can see here anti-VEGF is going under air. Here it goes there. So that's the step here, and this is how it looks like at the next 4 weeks. So you can see that the whole thing has gone away, and it goes away so cleanly, which was not possible to do with surgery alone. And this kind of thing is possible with the combo of these two drugs. So this is another case. So this is not to show that the anti-VEGF with surgery somehow acts like magic. It doesn't act like magic. So this case was operated, same thing. It had post-op bleed, and after 3 weeks, when the bleed started to clear, this is what it looked like. So you see the whole thing is just puckered over and this thing. So we should not be hesitant to do resurgery again. And if you do resurgery, possibly all that will clear much faster now, because anti-VEGF has removed the neovascularization and all the things which are pulling it. So it will be much easier to operate again. This is just to identify bleeders. So if you just again reduce the infusion pressure, pinch it, and you can see bleeders are here which were not seen before. So again, this is a good technique to prevent bleeding post-op. This is in the fluid exchange. I'm just trying to show here is that if you press this, if you apply too much air pressure and continue to suck out all the fluid which is there, then the TRD which you cut is going to press upon the posterior retina, and the red arrow I'm just trying to show, if you press too much, then the macula is also going to detach. So the fluid air exchange should not be too aggressive, otherwise you can have more problems than benefit at the end with the fluid air exchange. And obviously sutureless closure is very important, so that you can have a good outcome. At 3 days you should just not be able to recognize which eye was operated. So the common complications just which newcomers might encounter, just one or two of them, the common ones. So sometimes you are dealing with adult instruments and these eyes are very small eyes. You can just go and hit the retina there. So you can see a small break has happened there. So there's nothing to do there. Just go ahead and laser that part. Don't try to do PVD. Don't try to be aggressive in that area. Another lens touch is a very common problem because the cannula you see is very close there. Constantly there's no space for the eye to move there. So if it's just a touch, there's nothing needs to be done. It could just get away with the localized cataract. But obviously if it just got a big tear there, then obviously you need to remove the cataract. So, but small indents here, there, you can let them go and you might be able to get away with a peripheral cataract. And suprachoroidal fluid misdirection is another big problem, especially newcomers and especially in very small eyes, the cannula might misdirect and cause suprachoroidal fluid misdirection. Again, this is fluid only. If you're careful enough, just you inject air through the other port and then let the fluid egress out itself, so this should not be a problem. Just coming to the improving outcomes in stage 5 ROP, so lack of screening is a big problem which underlies this in our country. We get around 15 cases of stage 5 every week coming, which is very sad, and almost all of them are medical legal cases. So Dr. Anand has a very nice series on this. It's worth a read that how we should be aware about dealing with these from a medical legal perspective. And so this is just the ICROP again, of which Dr. Anand was a part of this, and so just divide stage 5 into stage 5A, 5B, 5C. So this is 5A. So most of these cases I don't like to do anything unless it starts to close up. So because if you start to go in for surgery in these eyes, mostly you'll have to remove the lens, and lens is a very important component. If you can let it stay and this funnel does not close, then possibly you can just wait and the child has an attached, sometimes the posterior pole might also be get attached, and if you can't make this better not to touch it. Stage 5B is the most common thing which we like to operate, and it's worth a chance to give them in the hope of getting some navigable vision. So these babies might really you might say they can't read and all that, but they might be able to benefit as much that they can go from here to the toilet and not crash or just recognize the parent is standing there. And so this is stage 5C. 5C again is just an extension of 5B. So if you see the left photograph, is just a few synechiae in 5B. So this possibly is just once you get rid of the synechiae while doing the lensectomy, it just acts just like 5B. But a case which is more advanced, like the right one where you see there is the iris is stuck behind the cornea. So these are more advanced cases to do. Dr. Jalali has experience about open sky vitrectomy, which you must have heard about, she talks about. So that all might be tried, and as Dr. Jalali might remember, Dr. Tracy had demonstrated a case like this, ma'am, where he likes to do 2-stage. So he likes to, he demonstrated in the workshop, he operates just the anterior part and does not touch the ROP at all. He just relieves the synechiae, removes the cataract and lets it go in the first sitting. And then, he'll maybe come back after a few weeks when the retina is more accessible and clearer to see. So he likes to do it 2-stage. And obviously the people who have assisted him, Dr. Anand also there with him and many others, he likes to use the 2-port vitrectomy. He's got the specialized irrigating kind of cannula, so he just does a 2-port. It doesn't make the 3rd port for infusion. All these instruments have irrigating thing in them, so he just goes through one and cuts, and the other cannula with light is there. So he likes to do that 2-port thing. So it's a masterful experience, madam, which we got to experience in that workshop and see him at work. So this is more of a bigger problem when you have a progressive stage 5 ROP, and so the cases which you saw just now were more, like 6 months old or 4 months old, which, it's a burnt out kind of a stage 5 ROP, where it's much more easier to operate. Case of progressive, let's say this child is at 40 weeks. Now, this is a bigger problem to deal with because it's a rapidly progressing ROP. There's a lot of neovascularization, a lot of activities there, a lot of plus disease there. So, operating these cases is more difficult and the outcomes are also much poorer. So, these are problematic cases to deal with when they are in early stage 5 progressive ROP. So the SN group has demonstrated this very nicely in this paper, how the pathoanatomy of stage 5 goes, and newcomers can look into this, and it helps to understand how the stage 5 tends to progress. And of course, Dr. Gopal published this article a long time back, which provides a good training guideline for the learning curve of young people who want to start in this and understand the pathoanatomy, and then they'll be able to operate these cases better. So is USG useful? USG is useful to some extent, but as we know that PVR D3, everything is closed. Once you start to open it, PVR D3 also opens. Similarly in this, once you start to open it, everything might start to open up or nothing might open up. So USG is not that useful except if you absolutely find something very open. And So if you have a lot of people like to operate in different ways. Some like to go from center to periphery, some like to go from periphery to center. So ultrasound might be helpful in these cases, and because if you try to enter with the cannula in this kind of situation, through the posterior part, you might just end up, going subretinal and creating a bigger break and a bigger problem there. So there's a role of UBM. Professor Azad published this a long time back again, that you can use in UBM in stage 5 ROP to find out where exactly you want to enter. And sometimes it's just not stage 5 ROP. You think it's stage 5 ROP because there's a retroentrant sheet there, but actually it could just be stage 4B sequelae. And once you start to open it, you find that some part is attached, but it's avascular. So it might just not be stage 5 ROP. So this is just like how I like to do it. It's a safe kind of entry. We don't go through the sclera at all. And this 23G MVR is going in, through which 25G instruments go in it. So it allows a good fit as well as allows mobility in these cases. So again, the three clear corneal incisions are made here. And then you can just remove the posterior sine K. You can do the lensectomy now. And this is, you get the dense retroretinal membrane which is there. And so the MVR is directly poked into this area where you find a little clearer areas there. Don't poke it through the retina, because again it's going to go through and through. So once you find an open area, you can just, so you don't need to necessarily make a cruciate incision. You can make whatever you like, and bimanual dissection is done just to push the opening open, and you can see it starts to open up. They can continue to open as much as you can. So you don't really, so this is from the center to out approach which is happening in this case. And as you continue to open it, it continues to open. You can relieve all these membranes and continue to open with bimanual. And this is the last bit of tissue which you see coming in here. And once you do that, there you can see there's a attached posterior pole behind, and there you can see the disc is there. So this kind of thing comes out. I'm just trying to say that, once you start to open these cases can continue to open up, and you can go through a sutureless thing like this, and in the end you will have something like this at the end, coming at the end of surgery. So it's a clean way to do it, in a sutureless way to do it. Not to say don't put sutures if it's still leaking, because a lot of manipulation, better to put a suture than just have an ego and not put a suture. So but you can get away with this, then it's fine. So just another case here which I showed a photo earlier. So this kind of outcome is very rare. This kind of outcome is not common. This is not to say that stage 5 has a good outcome, stage 5 has a poor outcome. Most of the cases have a poor outcome, but as I said, a lot of surgeons like to operate it. Dr. Gopal, Dr. Jalali, Dr. Dogra, a lot of surgeons and my teachers operate this, and a lot of others in the crowd I think also operate this. So it is a big help to these babies, and it helps them attain some kind of navigal vision. This outcome is rare, this might not happen, but the idea to show this might also happen in some cases. So it's worth an attempt. Don't just leave them as blind, and it's worth a try, and something might just work out. Sometimes, the central retina might not open, the peripheral retina might open up. So here what you see is the central kind of TRD is there, and the peripheral retina seems to be attached, although it's got some exudates and all, but the peripheral retina is attached. So you might sometimes get a peripheral kind of vision rather than a central kind of field. And of course, managing the pupil is very important. You just inject adrenaline, or just many people like to use iris hooks and pupil expanders. The idea is not to eat away the iris. The iris is a very important component. Many people like to eat away the iris. Don't eat away the iris. Iris later, also is very useful for cosmesis, and also very useful later if you have a reactive pupil, and it can act as a pinhole effect. Even if the patient is left aphakic, he can, have a pinhole effect and can have a much better vision than a pupil, which is like totally eaten away. And again, it depends on the posterior funnel access, what you are dealing with. The left photograph will have a much better outcome, and sometimes you try to open, nothing much opens up. So that is also a reality. Sometimes nothing opens up at all. And managing membranes is, as I showed you, is a good idea. So sometimes you just know which membrane is going to open up. The idea of showing this is, this white membrane which you see there, you don't know what's going to happen. Once you start to remove it, it might just start to open up. So we really don't know, but again, you have to be careful. You don't want to create breaks. So break is sometimes a big problem. Sometimes just a break happens, and you're shocked. Oh my God, a break has happened. So standard teaching, if you read in textbooks, is a break happens, time to close it. So breaks happen all the time in stage 5. You can, if you want to do a lot of manipulation and you keep on just leaving the cases because a break happened, it's a very sad situation. It's the only trial which you are giving to a stage 5 child. Anyway, we are not going to put oil, we are not going to do air fluid exchange and try to flatten it and do laser. Nothing like that is going to happen. So if a break happens, there's nothing to worry, just to continue the surgery. So here I'm just trying to show that you see a dialysis going to happen on the top right, and you see, so as you do this, all this fluid is coming out from the top. So I don't know how clearly it's seen. So this fluid starts to come out, but that doesn't mean you stop the surgery. Let it come out. You just don't do too much manipulation in that area. You continue to dissect in that area. Don't do too much manipulation, and don't try to keep on pulling that area. That everything starts to come in the center. And you continue to think this is the only chance the child has got. So why not, give it a full chance? A break should not stop it. Let's say a break happens here right now in the middle. I will not stop. I will continue to do it. Let it be there. What can be done? But at least something else might open up somewhere and the child might get something. So that is the idea. And of course, if you get hold of the macula, there's nothing like it. If you get a posterior pole, which might be detached, but still you got the posterior pole, some light at least starts falling on the posterior pole. Again, the child might be better off than a child in which nothing opens. Again, once you get it, don't try to be too aggressive about it. Let it stay. Sometimes the macula is very thin. If you just enter it, a hole might form there. Everything might start coming out through the hole. So better to not mess with it. If you get it, then just do some, little dissection around it. The idea is to prevent it from reclosure. So there should not be enough traction or something there around, or something which bleeds and closes this thing. The idea is so that it can hold like that for the rest of his life. And since these are not actively proliferating disease, so if you just open it, it might just stay open for the next few years at least till you see it. I don't use adjuvants. Earlier I used to use them, but most of the time if you try this, something happens and something goes subretinal, and then it's a bigger problem to deal with. So I usually now don't use it. I used to use it earlier. And just again improving closure again. So I'm just pinching here again and you see the bleeders are there. Sometimes you might not be able to see it because of very high VGFI or very high pressures inside the eye. So that will help you detect and close it. And as I said, sutureless closure is a very good idea in all these surgeries of stage 4 and 5. It is a very good cosmesis to the baby. You don't know, later they might need a trap, they might need something else, they might need a contact lens, and if you just messed up with the conjunctiva, and it becomes difficult for these babies. And obviously, cosmesis is very important. In ophthalmology, there's so many refractive surgeries being done. Everything is about cosmesis. Cataract is also about cosmesis. So we know the child might not see after stage 5, but at least if he's cosmetic, the parents don't have to remind it every day that he had stage 5. The parents don't have to remind it every day that you operated this eye and now it's more leukochoric than it was before. So cosmesis is very important. Of course, this is the most important thing, rehabilitation. You can do whatever you want. You can do stage 4, stage 5, laser, anti-VEGF. If you don't rehabilitate the patient and he becomes amblyopic, or he becomes has a lens detachment, or is not given proper refractive correction, it's as good as nothing again, because all that effort is wasted. So you should just not be let go. Rehabilitation is very, very important in these eyes. Surgery is just half the battle won, or I should just 10% of the battle won. Rest of the time what he has to spend for the next 70, 80 years is rehabilitation. If a good rehabilitation can be done, as can be seen in a lot of centers, Madam, I had a chance to visit the LV Prasad rehabilitation facility there, and how the people are walking with sticks and all. And I was just walking through the Kochi main road, the Shanmugam road is there, ma'am. And the whole corridor for that 2-3 kilometers has that stretch. If you see the tiled walkway on the side, has that way where a blind person, I have not seen this anywhere. The whole stretch for kilometers has that stretch in the middle, just like you see in some malls or the airports, where the blind people can walk. So that is something amazing which is there here in Kochi for the first time. Something which a blind person can walk the whole stretch of 4 kilometers and doesn't have to, seek help. He can walk with the caning. So I think that is a very important component which we need to look out for. So thank you so much for this oration to the Irop Society, to my seniors, Dr. Jalali, Dr. Anand, and thank you all of you for coming and taking your time. I hope it was something of value for time to you. Thank you so much for this kind of oration.
Thank you, Dr. Parijat. Thank you so much for sharing your vast experience, and you took us through all the steps. So honestly put, which cases to operate, which not to, and surprises both in terms of good and bad outcome. Most people only show their good outcome. So I think that also speaks volumes of the personality you are. We're again very, very proud of the contributions you make to the field, to the society, and to the country. Please share the dais here, and on behalf of the society, once again, thank you so much for accepting the oration.
So I want to add that, Parijat, every time I see your sutureless stage 5, I have tried, I have failed. Sushma Jaina tried, she's doing very well. So when I'm doing these surgeries, I'm telling the people who are observing me that I'm doing sutured, but there are better surgeons who are doing sutureless. Please watch them and learn from them. No, we all learn from each other. You're doing something which I think we should learn. I tried to get these 23, 25 gauge knives I have used. I'm still not good at it, but I will keep on trying because you are showing the way. Thank you so much. It's a great pleasure now to invite Dr. Supriya. She's here. Yeah, Supriya, please. She's going to tell us about the AIOC3 in India and tell us like what has changed for us and how we are going to handle the AIOC3 classification and how we are going to contribute to improve it in future. Rajat, as usual, very nice presentation.
Everybody. At the outset, I'd like to thank Dr. Anand and the entire IROP team for having given me the privilege and the honor of being able to present the IROP classification today for y'all. So the ICROP group was consisted of 20 retina specialists with 14 pediatric ophthalmologists from across 6 continents and 17 countries. And it's a very proud moment for India to have 2 of our very own ophthalmologists, retina specialists there, Dr. Parag Shah from Arvindai and our very own Dr. Anand Vinekar, who's here. Just before he leaves, I hope you can all give him a clap, because I've had the honor of working with Dr. Anand, and the passion that he has shown for the disease and the way he's taken it to another level is something that we're all being inspired by every day. So what was the need for the classification? It gave us guidelines about the disease, helped us. So it started with the classification in 1984, where they defined the zone, stage, and the plus disease. Was modified in 87 with retinal detachment, and in 2005, aggressive posterior ROP, pre-plus, and regression of ROP was defined and classified. So what was the need for the third edition of the ICROP classification was because it's the new era of anti-VEGFs now, and there are newer retinal imaging systems. So with the wide angle viewing systems, we're able to capture images till the ora. We're able to see these avascular retina till the ora, and we also have the OCT of the macula in these premature babies. There were also some inconsistencies in defining APROP. So in the developing countries, we found that it's not necessarily posterior, and hence there were inconsistencies in their definition and diagnosis. Also the plus disease, the trend varied across the generation as our imaging techniques improved, and we were able to diagnose the various forms of pre-plus and plus. We had to redefine it. As Dr. Anand already spoke in his talk about reactivation recurrence, what exactly they are needed to be defined and how to go about managing them. So basically it looked at how APROP became AROP. We spoke, they've defined regression, they've defined reactivation, further classification of stage 5, defined what persistent avascular retina is. As Dr. Jalali said, when do we treat them? 2 disc diameters. That definition is very important so that we don't go around treating every baby that we see with avascular retina. Also the posterior zone 2 has been reclassified, and the spectrum of plus disease has also been defined. So just a little more into that. So the zones, as we are all aware, starts with zone 1, disc-centric, and zone 2 remains the same, but a zone 2 posterior has been added, which is 2 disc diameters from the edge of the zone 1, that is zone 2 posterior, and beyond that the rest of the zone 2 becomes zone 2 anterior. So this posterior anterior definition was done with the ICROP3, and further what was defined is a notch, which is basically an incursion of the ROP lesion 1 to 2 clock hours, which goes in more posteriorly. This has been defined as a notch, and so how we define the zone is the most posterior zone of this vascularization with this notch. Then plus disease has been defined as the appearance of dilatation and tortuosity, as you can see, of these retinal vessels. And pre-plus is when it's also dilatation and tortuosity, but not enough for it to be a plus disease. So just like a precursor of it. And this recognition that these vascular changes form a continuous spectrum from normal to pre-plus to plus is what has been defined here. This spectrum has been defined here. And these vessels need to be assessed only within zone 1 rather than the narrow field photographs, and rather than from the number of quadrants of abnormality. Then the stages of ROP, as we all know, demarcation, the ridge with plus minus popcorns, or the vascularized ridge is there. So if there's more than one stage, the eye is classified by the most severe stage. Now, OCT has also helped us realize how how these ridges are visible, and if there's a little confusion between stage 2, stage 3, OCT kind of clarifies that for us. Here you can see the demarcation line in this stage. It's still being an intraretinal lesion, and now you can see extraretinal vascularization here in this OCT. Now, because there's been so much data and so much work, thanks to the IROP Society and our mentors here, they found that in the developing countries that we are able to see aggressive ROP in larger preterm babies also, and not necessarily in the posterior retina. So how it's defined is basically the tempo of the disease, how aggressively and how fast it appears and progresses, and not necessarily the location of the disease. So the posterior has been dropped and it's been reclassified as aggressive ROP. Here you can see the dilatation, tortuosity, the very ill-defined junction between vascular, avascular retina, very well seen in this fundus fluorescein angiogram, and significant capillary non-perfusion area seen here. Stage 4 describes partial retinal detachment which either spares the macula or involves the macula in stage 4B. And another form of detachment where the periphery is still attached, but in the center you see a volcano kind of tractional detachment has also been described. These detachments may be exudative or tractional, and they may occur either in treated or untreated eyes also. Stage 5, as Dr. Parijat just described, has been reclassified into A, B and C, and stage A is when you can see the optic disc is visible by the ophthalmoscopy. Here you don't see the optic disc, it's a closed funnel detachment, and here you have anterior segment changes. Regression, Dr. Anand has already spoken about regression, where the disease involutes and either completely or incompletely. You see involution of the tunica vasculosa lentis, you'll see better dilatation, greater clarity, and decrease in the vascularization. It can be either post-laser regression or post-anti-VEGF regression. Persistent avascular retina has been redefined at more than 2 disc diameters, can be that has been spoken by Dr. Anand, and he has also spoken about reactivation, so I'm just going to skip that. The long-term sequelae could be tractional, any form of detachments, tractional, rhegmatogenous, exudative, retinoschisis from chronic traction. These peripheral avascular retina is more prone to thinning, holes, lattices, and thanks to OCT, we've also seen the various anomalies that can occur at the macula. Even OCT angiography helps us in redefining this foveal avascular zone. So what ICROP3 is just forms a point in the journey towards improving ROP care and outcomes, helps us to understand this acute phase ROP, regression, reactivation, the long-term risks of this peripheral avascular retina, and how long we need to follow these reactivation cases, and helps us quantify using our imaging methods. Thank you so much.
Thank you, Supriya. Any 1 or 2 questions anybody has? Immediate questions while the next speaker is getting ready. Tapas?
Just one thing. Not with this presentation, I would like to share my experience, a small experience, because initially I was very much actively speaking in the meetings. Now I am seeing very few cases since our neonatal ICU has improved so much that we see only few cases of APROP, the AROP should say, or the disease appears and regresses.
Yes, yes. That is the experience worldwide, that if the NICU practices are good, they have high quality care in terms of nursing, in terms of sepsis control, nutrition, health. We are not having good maternal health. So we have teenage pregnancies, we have mothers who are really anemic, or they're exposed to a lot of inflammations because of bad menstrual hygiene. So they are the ones who are delivering these early, and those babies, now Tapas is doing some studies, these babies are born with a bad retina. And then that of course worsens with the additional things. But that is something which we are not able to control. So this is what we are dealing with, is the third epidemic. where both the things were involved. The West already cured the first epidemic by the ways that from their birth. And that is where it will come back. So as long as you are saving only 27, 28 weeks and above, your good neonatal practice, good maternal health will let the ROP go away. But the moment you start having a lot of IVF babies and a lot of 24, 25 weekers, then it will come back. And the third is now we are looking at the maternal factors. Excellent. Tapas, go ahead.
Thank you, ma'am, and feel great to be with this audience here. And I would just quickly take you through the ROP training, the need, the program we have, and how we take it forward. This is rough data on the ROP trend in the rising trend in the state of Odisha. You can see that the number of babies to be cared for is increasing, partly because of our greater reach to those who were previously not being screened, and also the increased survival of the babies born premature. This is the rough statistics. Now our goal was to eliminate the ROP blindness in the state of Odisha. We know that we can't make it zero, but we can go as close to zero as possible. This is how the babies born, and our aim is that none of these babies go blind. And the model that we followed in the state of Odisha, that we realized that for a sustainable win, the care there need to be local leaders, and care need to be decentralized. Otherwise, the availability versus the need, the huge gap is going to remain a challenge to us. Now, these are the basic parts of this model: initiate or strengthen the ROP screening, build up the capacity, and which we are going to discuss, or training, hand-holding once the training has happened, then remote mentoring, and final exit. This has been our plan, and the targets include, in fact, we would love to have everyone aware of the need of ROP, like everyone knows about polio vaccine or vaccination of their child. But if you keep it the priority, definitely these are the priority for the training: retina specialists, general ophthalmologists, pediatric ophthalmologists, pediatricians, neonatologists, obstetricians, and optometrists, low vision and retina specialists, general public. The type of, these are in brief, the type of education program, the duration depends upon the pre-existing skill in them, skill in the form of with the indirect ophthalmoscopy in handling the babies, examining the babies, and laser in the adult, indirect laser and laser in the babies. So accordingly, the program, the duration of the program is fixed. Usually what we have observed that those who are retina specialists who are already doing indirect laser and also indirect laser in adult roughly takes around 2 weeks to 4 weeks to master the laser and intravitreal injections in the babies, in addition to screening and other screening and care for the retinopathy of prematurity. But those who trainees who don't have any experience on indirect ophthalmoscopy, just direct ophthalmoscopy, in them it becomes hard to make them independent in all the screening, the ROP care, injections and laser. For them, usually it takes around 2 months for being proficient in examination of the babies and intravitreal injections and diagnosis and decision making. Then the laser, the capacity for the laser takes more time, and they are called for another training. We have all the 4 campuses, and we are privileged to have an AHA group led by Subhadra ma'am, and the 7 pediatric retina faculties across 7 LBPI campuses. Those go through the training activities and formulate and modify the training protocol from time to time. In addition to this, the CME activities to improve awareness among the pediatricians, the neonatologists, and the child care provider continues. Now, what are the materials are set up for the curriculum? Now, this includes the efficiency in portable laser, portable indirect ophthalmoscope, laser, art and science of examining the babies. It's not just jumping directly to just get a fundus view, but how you hold the baby, how you take care of the babies, how we were getting acquainted with the process, the moment the baby comes for the check-in, how we prioritize them, how quickly we examine them, how we create a mini NICU atmosphere within the campus itself, like they were in the when they were in the NICU or on the outside. So these all depend on how quickly we see, how we handle them, and finally check out safely and in a short span of time. Now, imaging, the additional training includes imaging, pediatric retinal imaging with different pediatric retina imaging devices that includes RedCam, Forus, or ultra-wide field imaging devices like Optos in a flying baby position. Intravitreal anti-VEGF, both in the injections, both in the operating room setup as well as bedside. Decision making, counseling, follow, refraction, low vision services, and different as the new the trainees come, they have a lot of questions and need guidance, and the lectures, the reading material, the atlas, all these things helps in the presentations, help in learning, and also help them use these in the later part of life when they become the trainer for the other trainees. Finally, it is important on the how to document it, the legal aspects, the public and private partnership, how to build up a screening program, say for example, how I was taught by Subhadra ma'am, and finally I took it forward, and we have started from 2 units to now we are in around 35 NICUs and 15 districts. So that the skill that we have learned from need to be transferred to the training so that the program continues. So these are the hands-on trainings, as we can see here, with the examination with the indirect ophthalmoscope, intravitreal injections.
Please put 4 minutes timer, because you had put 6, it was 10 minutes. Good.
So intravitreal injections both at the NICU as well as under operating microscope, but handling the baby, many a times you see these babies, they come especially in low resourced areas where the babies are discharged much before then they should have been. So as a result, these babies are very, very sick. So how we handle them, how we make sure that before examining that the baby is well or not, how we or the proper feeding practices, how we examine, these are very important that need to be learnt. Again, establishing the neonatologist and ophthalmologist team partnership is very crucial to initiate this screening process, to continue for the screening process to continue and expand, and get the cooperation from the nursing and the child care provider. It is very important how we build up a team with them, that also the training need to learn. This is training, as we know, slowly as the program expands, all of us finally in a day or other we need to get into the telecare practices. So all of us need to get used to all the telecare models available: store and forward, capture, store, forward, read, and communicate with the parents about the diagnosis followed by treatment, and different other modifications of the program available. Say for example, this pictorially shows the real-time ROP telescreening. This is synchronous telescreening where the babies, when they are being screened, are evaluated by the ophthalmologist or the ROP specialist, who analyzes the images and immediately informs that to the parents and counsels them, and they get checked out that time only. Now the team goes, you can see how a team is built, what are the things to be taken, and how a plan is made for traveling to the peripheral institutes. These also need to be learnt. These are the parents gathered the peripheral institutes. The images are taken, finally analyzed synchronously at the same time, and the parents are counseled and checked out. The advantage of this is that any number of persons can get logged in. So any trainee, whoever is there, he can log in and evaluate the babies, and he is finding, he can analyze the images and make his diagnosis, and he gets corrected during the analysis by the ROP specialist. The advantage of this is that many a times you see those who come in the government units, they don't have a long time for the training. So they prefer something around 2 weeks to 1 month. So again, even if they come, 2 months training becomes virtually 25 days. So the 4 or 5 days goes, then usually they take leave, and during that period also they have other hospital work. So finally it becomes 25 to 26 days. So what we found that if you get them, initiate them in the training and follow them up for few sessions in this real-time screening where the imaging goes and they examine bedside, the babies get examined by them bedside, and finally when we counsel, they get trained also. So that way it helps, makes a huge difference. So the dummy eyes we have in these instruments, they help a lot in newcomers, those who don't have any experience on examining the babies. So they start with the dummy eyes and imaging, and finally, so monitoring of training and treatment program is very crucial. Courtesy Dr. Subhadra, here we can see that the student who once was trained in ROP was finally could take care of the baby, his own baby who had severe ROP, who treated successfully, and this is a proof, and this is what we want to see all our trainees who come for the training. They should become independent in the ROP care, and so that if there is, you have your own baby, you should have that confidence that yes, I can train. So pre-training evaluation, post-training feedback, and follow very crucial to modify the program and improve program from time to time. So thank you so much. I acknowledge all the support that we have got in the training of the ophthalmologists so far in ROP.
Thank you, Tapas. Great work. I think we can take questions later. We'll have Karobi tell us from the Indian ROP Society, she's the ambassador, what all work the members have done over the past 1 year. And while she's getting ready, if there's any quick question anybody has on the training programs. Abhijit, go ahead.
Sir, Madam, about the training program, there's one real problem is that practicing ophthalmologists usually they want to come suppose 2 hours and then maybe afternoon 2 hours, and it is very difficult to arrange that way in an institute. So if you people think over it and get to a practical formulation of training, means the people like we trained, we go there, stay for 7, 10, 15, 2 years fellowship also, but here I think practically not possible for them also to close the practice and come for 2 months even, or 1 month even.
Yeah, to address that only, what Tapas has been showing, and we can also do that, that some of the theory we can do on webinar. We have to work now on Sunday morning 8 o'clock or in the night 6 o'clock. So have the webinars, give them the pre-training material, they can go through it, videos, text and all. So the theory part we can do that. Then, they can come for 1 day, at least 1 day workshop, or 1 day or 2 days, and teach them on the eye at least how to take photographs. Then when they go back, then they do the photography, and we on Zoom are monitoring their photographs and asking them to interpret 5 babies, 6 babies. So they start learning that. Then when they're a little better, then they can come back for 2-3 days. So we are trying to tailor make to their needs, because many places they are the only ophthalmologist in their place. And if they shut down for 1 month, then other things suffer. So even before like that, one of the doctors, she wanted to learn surgery from me. She was in Gujarat. So I said, okay, I do surgery only 2 days a week. Why should you be here for 1 month? I will charge you for 1 month. But you come Monday, Tuesday for surgery, you go back on Tuesday night. Like that, she came 4 times. She had to spend money to come, but then she was able to do surgery, and now she's doing surgery. So I think in individuals, we can tailor make, and the training is not free. Somebody has to pay for it. But we can modify the structure in such a way that everybody benefits, and there are no losers. Yeah, I think we'll have Karobi go ahead.
Thank you, Irop Society, and Subhadra, Anand sir, and Parijan for inviting me to talk about the ambassador program. Our ambassador program, I should say, is going on very well. As I always maintain that everyone in his own capacity is an ambassador, and whatever little you can do in the way of awareness is something which goes a long way towards propagating the message that we want to convey to the general public as to how to treat the premature babies, when to get them for examination, and how to prevent the disease. So just going over a few activities which were done over the last year, I had been sending repeated messages across the group for people to send their thing across. I did get some of them came early, some of them came very late, but whoever has sent it to me, I've tried to incorporate it. But a sincere request is that if you all conduct any activity, why don't you just send it to me on my personal WhatsApp at the time that you all have done the activity. I collect it, I collate it, and I will put it. So whatever activities you are doing, it's not as if it's not, nobody's taken heed of it, So every little thing counts, because with one drop, the sea is made, and this is what we are aiming at. So let me start with the World ROP Day or week activities towards the awareness. Now, first, these people celebrated by cutting a cake on World ROP Day. This is the MGM Institute where Dr. Swapnil Parchand, Aditi and Anil Gangwe are doing the ROP work, and they had released a small kind of video where towards awareness. And give me 1 second.
You. Hello. In India, every year around 3.5 million babies are born prematurely. Out of these premature babies, around 10 to 15% of babies have severe form of retinopathy of prematurity. It is our duty to get these babies screened for retinopathy of prematurity within 30 days of their life. No baby should go blind because of retinopathy of prematurity. Thank you.
The next was Dr. Jitendra Jithani, who had released posters at his institute over there at Baroda. Following that is Dr. Bhavin and Dr. Rekha, who are from the SNVM hospital, and they also did a lot of awareness.
हेलो फ्रेंड्स, मेरा नाम है डॉक्टर भाविन और मैं स्वामी विवेकानंद नेत्र मंदिर की तरफ से डायरेक्टर और आई सर्जन बोल रहा हूँ। आज वर्ल्ड प्रीमेच्योरिटी डे। काफी लोगों को पता होगा कि प्रीमेच्योरिटी मतलब अधूरे महीने पे जब भी बेबी का बर्थ
of what has been done. This was the message that she gave following this.
नमस्ते, मेरा नाम डॉक्टर रेखा सिंगल है और मैं आंख के पर्दे की निशान सर्जन हूँ। आज हम जो है आरओपी यानी रेटिनोपैथी ऑफ प्रीमेच्योरिटी के बारे में जानेंगे। ये जो बीमारी है वो बच्चा जो भी अधूरे महीने आता है, 8 महीने से पहले आता है या जिसका जन्म का वजन 2 किलो से कम हो, उन बच्चों की आंख के पर्दे की बीमारी है। इस बीमारी
very commendable. Painting competitions were done on that day by children who were initially premature, and this is the outcomes. Beautiful paintings have been done by these children. Now, next, to come to LV Prasad, because a combination of all the 4 campuses, they have done extensive amount of work towards awareness. I think ably guided by Subhadra, Dr. Tapas. It's really phenomenal. So here they conducted a roadshow, TV interviews, they gave numerous lectures to the general public on ROP awareness. Again, there were a lot of activities where they are Irop model. Then they had a kind of a workshop again for a lot of students, and Dr. Tapas demonstrating how the FFE is done on these children. These were all activities which were carried out between 2022 and 2023. This is a road show again, and this is a culmination of all the activities that was done. Pardon? Children's Day celebration again was done at LVPI, and they sort of had certain skits which were done, and they really sort of hit it off on that particular day. Then this was at the Car campus, that is where, at Hyderabad, where Dr. Akash and Dr. Deepika were instrumental in this under Subhadra's guidance. This was again from the GMRV campus of Visakhapatnam, where they gave a message on World ROP Day, and they emphasized on the newborn eye health for other neonatal conditions also. And the awareness was standalone events which were done, but everything moved towards awareness. This is again the road show, the awareness along the beach road at Vizag, and this is again the activities. Then at the KVC campus, they decorated the campus with purple balloons, which is the color of the the World ROP Day, and they also gave some awareness lectures for this thing, and some cuttings in the newspaper or press conference was also arranged. Coming to Dr. Anand, whose contribution is no less, and he also released a poster from the Irop Society on World ROP Day, and this poster is such that it can be used by anybody who wishes to inform their patients about the need for showing their children early. And there were also like from the Kid Drop, there were other posters also which were distributed. Then Dr. Subina and Dr. Diksha Katoch and Dr. Mangat Dogra from PGI, they also released a pamphlet which gave the PGI and ICU nets, which were small information guidelines as to what people have to do in the NICU. And they also have a published article to their credit. At Anganwadi, Dr. Anupama Bapal also carried on the World ROP Days activities quite effectively. This is at the Kasturba Hospital, where the lectures were given, and an awareness activity was carried out. This was at Coimbatore by Dr. Abhikshay again, where there was a display of posters giving information about preterms and how to manage them. And this is from Dr. Vasumati of Chennai, where she had arranged a musical program where she spoke extensively about the need for this kind of awareness in ROP, and there were celebrities also who had come and endorsed the same. Time and again, she's had celebrities coming in who give a little bit of this, mostly in Tamil. So I would request that anybody, like whether it is in Gujarati, whether it's in Marathi, or whether it's in Konkani, or any language, if you can get hold of somebody significant whom people would listen to, ask them to give a short message, this would help. This is from my end, where I had requested Arnab to flash a few captions on Republic TV, and he helped us out in this way because in 2 sessions of his lasting 1 hour each, continuously they had kept on repeating these kind of captions to awaken interest. And now coming to the academic activities, this is like right from a cutting in the newspaper elucidating a 400-gram child, how it was managed effectively, it increases the awareness in people automatically. This is the AIOC program, starting with the youngsters, where they did something on medical legal aspects, which again is commendable, right to the big stalwarts who go to the SAO conference and speak over there on this subject. It's all towards awareness. Then this is from my end, where I had a lot of standalone lectures at numerous forums, whether it was a genetic forum or Academy of Cerebral Palsy, or it was a low vision thing, where I was speaking about ROP association with that problem. And my first quest is always to increase the awareness, because the target population is generally optometrists, they are nurses, sometimes there is lay public, and sometimes other specialty doctors who are concerned with this disease. These were again from our end, where we had created a lot of posters in different languages, and these are distributed and given to hospitals so they can put it in front of the gynec ward or the pediatric ward. So people who come and sit over there can automatically just read it, and nobody needs to tell them, and then they know that this is a problem which has to be tackled. We had created a lot of videos, animation posters. This was not last year, but year before that. But what I meant to say is that these are videos, posters, which I have posted time and again on the group, and anybody can use it whenever you want to show anything on ROP, so feel free. This is on stages of ROP, how ROP is created, and the posters. Now in Mumbai itself, we have a Haji Bachchu Ali Hospital, which has got 4 people dealing with ROP, that is Dr. Anand Subramaniam, he's the head, Dr. Ashish Doshi, Dr. Sarvesh, and Dr. Prachi. They have got a RedCam in their facility, and now they have started a fellowship in pediatric ophthalmology, squint, and ROP. This is, I think, really, really a good kind of initiative. And then coming back to Dr. Subhadra, she has her own video on the basics of eye testing in ROP. In newborns, yes.
This is for newborns, for general newborn care. This WHO has accepted this video, and they have distributed all over the world to different units for universal newborn screening.
Very good, Subhadra. We all appreciate the work that you're doing. And then she is a diehard ROP sort of proponent. So you see she herself is dancing on the stage, and you'll see her dancing on the stage.
People will think I don't do 7 in the night, 11 o'clock.
अरे सुभद्रा का डांस मत ये करो, interrupt करो. You all must see the dance.
To get the youngsters to come and talk to me so that I could give them the poster.
And she danced within the crowd, and I think it drew a lot of attention. So when people come, then you can give them the message very effectively. So thanks, Subhadra. You've done a great job. See, everybody is dancing along with her. And there were posters which were also displayed. She went on air also to again talk about the same. And they have released a ROP Atlas, which was released at all their 4 campuses. because they have completed about 1 lakh babies who have been screened and treated for whenever needed for ROP. Then this was again displayed in Vijayawada campus. Again, they had a Times of India story on an ROP baby. She is at the India Science Fest where she spoke and again distributed her posters. Subhadra is looking very nice over here. And at the CAR campus also where they have sort of displayed this. And this is all the campuses where they have done. They had a FM program also. Kya hua? Okay. Yeah, I'll just finish just now. And then special laurels to Dr. Paraksha and Anand, who have contributed towards the ICROP 3 classification. It's really a proud moment for India. And again, his tenets in the guidelines, NNF guidelines, which is commendable. Then Dr. Anand and Dr. Rajvardhan Azad, they have started this awareness activity by going to different states of India, and they have had already 2 meets where they have done one in Delhi and the other one was at Calcutta. So this was the first zonal meeting at Harjanj Hospital Medical College, again to increase the awareness. And this was at Kolkata RIO Medical College, where the second one, you see the amount of people who have come, it's very crowded. And now we progressively see that for all our ROP talks or ICs or any kind of workshops which are there, they are generally very crowded. Earlier there used to be scant few people, but there is a growing interest because of all this awareness. These were awards which a lot of people have won. And Dr. Akash Belenje won the Best Paper Award at Warangal. And these were at the 5th World ROP Congress, where Dr. Tapas Padhi, Dr. Indrajit Kaur, Dr. Subhadra Jalali, and Dr. Saurabh Kumar won awards. And the best poster by Dr. Tapas Padhi was at Nagpur. And the most important thing is Dr. Rajvardhan Azad, he has been selected now to get the Lifetime Achievement Award at the next VRSI meeting. And this is all because of his commendable work in ROP over all these years. This is certain statistics which were sent by Chanda Sethia from Korba, Ruchir Mehta from Jamnagar, Ajay Kapoor from Ludhiana, Abhishek Kotari from Jaipur, Rajiv Gandhi from Sholapur, Anand Vinekar, Bangalore, Subhadra Jalali from Hyderabad, and Anand Subramaniam from Mumbai. They have listed the number of cases they have done, the amount of surgeries, and for what duration of time. And we need more inputs from everybody. It doesn't matter, even if your numbers are small, just send it. Don't feel anything.
Karobi, that 1 lakh is from all the 4 centers, not just Hyderabad.
No, I mean,
yeah, I mean
you encompass all the 4 centers.
Yeah, so that's like all 4.
And this is from Dr. Supriya, the rotor-up. She was a late Sendi, so I put her as a separate thing. I didn't have time to collate it with others, but these are her statistics in Chennai, and they have also done a lot of work over the last 2-3 years that they have started. So congratulations. And these were just some statistics which came in. Thank you so much for your kind attention.
I think commendable work by a lot of members. I think only thing we need to tell Anand that there are many people who want to join the membership. They are not able to get access. And so we should, open it up and see how people can join the membership and, help us there. So it is in third week of July in Surat. In Surat it will be there. I think he announced 20th and 21st of July. Yeah, 21st July. 2 days. Usually 1.5 days it is there. Yeah, we can discuss with them. Usually they have in the afternoon of second day, That's what we do. Usually we do have hands-on, or it can be one day prior, or it can be on the last day, so that program still upcoming. So yeah, I'm sure it will be there. Okay, thank you everyone, and we are missing Anand. So I request all the speakers to please come and take a picture. Tapas, Supriya, Karobi.